Uh, Hey everyone, my name is Nima Fathi. I'm the second year master student at McGill University. Attention, please. Attention. Thank you. So today I'm gonna talk about something which is not that relevant to the neuroscience, but we have some reasons for doing something like that. So the model is called DeCoDEx, Confounder Detector Guidance for Improved Diffusion-based Counterfactual Explanation. It is our latest paper that got accepted to the middle 2024 recently, and we're gonna present it in like 2 months. The work is a shared work with the contribution of me and Amar Kumar from the Probabilistic Vision Group under the supervision of Tara Albert and also one of our colleagues at Google Research Montreal. So as a disclaimer, as I said, this paper is not related to the neuroscience part, but we have a very, very giant private data set of MS with the 3D brain MRI acquisitions. The reason that we are in this talk moving toward the chest X-ray images is that these kind of like data sets are real easier to work with, and we are basically doing this work as a toy data set or like as a toy experiment on these real world scenarios, and we're gonna extend it to the brain MRI private data set that we have. So without further ado, let's get into the motivation of the work. So, okay. So the motivation of the work is that, let's say that you are going to a clinical clinic to examine your chest X-rays. So there are like a couple of people that are sick, and there are like a group of other people that are healthy. So let's say that in this case, all the sick patients are coming with a device on their chest. So you can see with the arrow, there are like some devices that you can see here, and all other healthy patients doesn't have a device on their chest X-rays. So what your deep learning classifier understand is to basically learn the shortcut that is here. So it would be prone to latching onto the dominant confounders. So in this case that we have 100% correlation between the devices and the sickness, there's nothing wrong with doing something like that, right? So your model can safely latch to the spurious correlation that is inside the images. But what if we make the scenario a bit more realistic? So let's say that there is a minority of the, or a portion of the patients that come in, they're sick, but they don't have the devices. They don't have any pacemakers in their chest. They don't have any other devices that is attached to their body. And also on the other hand, there's some healthy patients that come to the clinic and they have some sort of device on their body. So what would happen is that your model would latch these into this shortcut that is not true and it's biased, and rather than the disease markers on the target class. So we want to sort of solve this issue of the bias in the medical imaging context. And as I said, there's like my majority of 90% of the patients with the sick devices and 90% of the majority patients with a healthy that are doesn't have a device. On the other hand, there's the minorities or special cases that I talked about right now. So what is the background of this work? So people are basically trying to solve this issue of the classification in deep learning with a touch of explainability. What is the explainable model? There are the family of models that try to open up these black box classifiers or deep learning models that understand what is the thought process and reasoning behind these models. So what one sort of these or one subgroup of the family of explainable models are counterfactual generation or counterfactual inference models. So what a counterfactual model does is it tries to answer to the question that what would the person look like if they were not sick, for instance. So let's get into the details of counterfactual generation with a visual example. Let's say that we have an original image of this, like this, and it comes from a patient with the sickness of pleural effusion. As you can see, there's a pacemaker in here in the image, and the bottom part of this lung is actually destroyed by the pleural effusion. If we try to create the counterfactual, which would be a patient, suppose that you have the same person, but the person is not sick, what would happen to the person visually? So one sort of counterfactual could be like this. As you can see in the first image, there's not much difference inside the lungs, and everything is basically the same. But the differences are happening toward the medical devices. On the other hand, we can have another explainable counterfactual model that instead of concentrating on the medical device, it basically preserves the medical device to a high level, to some extent, and also a concentrate on the disease biomarkers that we can see on the left-hand side. So this is basically the medical device hasn't changed in the first has changed in the first one, which is not what we want from our device model. And on the other hand, the second model, the medical device is preserved and the concentration is on the disease biomarkers. So the counterfactual generation exposes the bias. As you can see, even in the first case, you can see there's a bias and the model is focused on the medical device. But the problem of addressing device is still unaddressed. So how people in the like in their previous works solve this issue is to use a bias mitigation methods that can be helpful. What is a bias mitigation method? So I'm pretty sure that a lot of you know how to train a classifier. In the a normal way of training a classifier, we use empirical risk minimization, which basically you minimize the loss towards the different classes that you have. But there are like some sort of bias mitigation methods that try to address and understand there's a bias in your model. For one of the most useful of these methods is group DRO, or group distribution robustness optimization. And this model needs the subgroup information. So you need to have the labels for the presence of the artifact in your images. And this method, for example, tries to maximize the accuracy of the worst group. And with doing that, it hopes to basically remove the bias. But it doesn't come free in the model, and it basically reduce the the accuracy of the majority groups with the expense of basically increase the accuracy of the minority group with the expense of reducing the majority groups. So these methods can be helpful, but as I said, you need a lot of information for the subgroups. But our proposal in this context is to use a pre-trained confounder detector and also the guided diffusion to focus on the correct disease pathology. So what do we mean in this context is that, suppose that we have the same data. Now this one, we synthetically add a dot in the center of the images for the sick patients, with like 90% of them have this dot, and 10% of the healthy patients also contain this dot. So we have the same imbalance again, but this time we are only synthesizing the data set to make it a bit clearer to the audience to show the changes. So when you use a baseline model, which is a normal model that doesn't use any debiasing, as you can see, the concentration and focus of the model is to remove this dot. As you can see, there's some changes that happen to dot, and there's no concentration on the part of the image which is related to disease biomarkers. So it shows that our model is learning to latch to the shortcut instead of understanding the actual disease biomarkers. But on the other hand, our model can perfectly preserve the visual artifacts and also concentrate and makes more changes to the disease biomarkers. But how this model works, we can get into the bottom of it after seeing the main contributions. So the main contribution of our work is that we use a device counterfactual generation via diffusion models to basically direct the explanation to the structure that we're interested in. Then we mitigate the bias in explanations, as you saw in the examples. And at the end, we also show the usability of our counterfactual with augmenting our training data set. We're going to get to the bottom of these concepts in a minute, but before that, let's just talk about the methodology. So what is the methodology of this work? So it's a very easy and easy to understand model. So it has three different phases. Phase one is to training a diffusion model. I'm not going to talk about what is a diffusion model, but at a high level, the diffusion model is a model to generate different things. So it's a part of a family of models to generate images based on a condition and basically find the data, the space that the data is inside it, or the subspace of the data. The phase two, we train a classifier and a confounder detector, and then we get to use all of these things together within the inference time. So the inference time, we pass an image of, for example, a patient who is sick, and we use a guided diffusion approach to synthesize the counterfactuals based on the classifier and the detector that we have. So what is a guided diffusion? As a disclaimer, we can use any pre-trained models in the first two steps. So you don't need to train a diffusion model on a classifier. You can use any off-the-shelf classifier and detector that is trained for the same purpose. So what is a sequential denoising or a guided diffusion? So from a high-level concept, we start from an input image, which in this case, there's a sick patient with pleural effusion in the lungs. We corrupt the image with noise, and then we iteratively refine image in top steps. So we denoise this image with the unconditional diffusion model, and then we pass to a classifier, and we use the signals and the gradients from the classifier to refine it just a bit better. And we repeat this step, top steps, and we basically get our counterfactual image. But what we actually do in our model is to just add a touch of the confounder detector. So instead of using the classifier, a black box classifier that we don't know how it makes it decisions upon, we use a detector, confounder detector. So the classifier is trying to classify the healthy versus sick. But in order to understand what is the visual artifact that we are handling in this situation, we need to understand some sort of have an understanding of what is the shortcut that our model is latching onto. So in order to understand that shortcut, we also train another classifier, which is only trained to see the presence of this dot, or the, on the other context, the device, medical devices. And then we try to use the signals to basically revert the or change the classifier decision and also preserve the same original artifact. So we want to go to a subspace that is defined to basically be debiased. So we are going from a space of the, for example, in this case, sick patients, to another subspace that is healthy, but also preserve the same condition, the condition being having a dot. Or in another case, can be a sick patient without the dot, or the minority. So we want to preserve that condition and basically force our generation to a subspace that is meaningful and is not biased. So how do we do it in each guidance steps? Let's just open it up. So the first one is to train an unconditional DDPN. We use the unconditional DDPN to refine or denoise this noise image of Z of tau. We get X of tau, which is the noise version of the image. So we do a full pass of the unconditional diffusion model. Then we calculate the classification and detection loss on the black box classifier and detector. We easily backpropagate the loss with the some equations that I didn't want to bother you with, which is very easy to derive from the diffusion model context. Then at each guidance block, we do a sampling. So with the changes and backpropagation, we have a bit refined data distribution. Now we sample from this refined distribution, pass it to the next block of guidance. So we do this guidance top plus one steps in order to get our refined version of the counterfactual. And that's when you put it all together, you're gonna end up having this model that has the guidance steps and basically goes from an image to its counterfactual part. So what are the results that we're gonna see in this context? So the results is that we evaluate the counterfactual, we evaluate them both qualitatively and quantitatively, and also we do another set of downstream experiments that we augment the data set with the counterfactuals that are generated. The reason that we do that is that first we want to test the usefulness of the counterfactuals that we have generated to see if they're actually legitimate, are they useful or not, and also we do it and we're gonna boost the performance on the minority subgroups. So first we can see some qualitative results. This is the dot data set. This is the case that this a healthy image doesn't include any dots. The baseline model, which is biased, I'm not sure if it's visible, but you can see some dots that are generating in different parts of the image instead of concentrating on the disease markers. So it shows that the baseline model is only latching to that spurious correlation, which is not relevant to the disease biomarkers. On the other hand, decoder, we don't see any dots in any part of the brain, but this is the disease pathology that you can see the changes are happening around the area of the interest. You can also see the qualitative results for the device data set. This data set doesn't have the dot. It's a real world scenario. You can have many different devices or support devices in different locations. So it's a more complicated data set that is aligned with the real world scenarios. So in here, you can also see that, for example, when we are starting from an original image, which is healthy, in the baseline, the changes are happening to the device data set. There is no changes in the area of interest, but for ours, you can see the changes are happening to the area of interest, and the counterfactual actually makes sense. You can see that on the other hand, for the original image of class sick, when you want to create a counterfactual which is healthy, in here you can see that all these devices are getting changed or getting removed in the baseline one in DeCoDEx. They are mostly preserved. I'm not gonna say it's 100% preserved because we are not using any mask or any information about the location of these devices or even the number of devices. So we're only using a limited information, but you can see the concentration changes are happening to the right area of interest. And for quantitative results, we are using a lot of different metrics that are relevant to the counterfactual work, but I'm not gonna talk about the metrics because the definitions are a bit high level. So let's just concentrate on the first two metrics that are very important for us. The first one is the classifier flip ratio. which shows that how many of the classifications are actually correctly changed at the decision boundary. For is like 100%. On the other hand, the DRR shows the detector robustness ratio. And as you can see in this case, for the baseline model, only 25% of the counterfactual images preserve the actual visual artifact. So it shows that it's basically latching to the shortcut. But on the other hand, for us, it's like perfectly almost 100% accurate. And so in the last part, we're gonna use another set of experiment with data augmentation. What is the data augmentation? Let's say that you have your training data set. You use your baseline model or DeCoDex to create some counterfactual images. You add those counterfactual images to your pool, and then you train a classifier and predict and see the accuracy. So that's how we augment the data set. So if you don't do any augmentation and you use ERM or the normal way of classification, this is the results. If you use the counterfactuals that are generated via the baseline model or the biased model, you can see there is much difference between the majority and minority groups. Even you can see some decrease in performance. It shows that these counterfactuals are not informative. You are not adding anything to your classifier. But on the other hand, when you use ERM with DeCoDex counterfactual or R model, you can see in the majority groups, they're almost the same or even better. But the thing that we care about is the minority subgroup where we had the special case. You can see that there's a 2 or 3% increase in the performance in the minority subgroups. It shows that we are adding something to our classifier and the information is actually preventing the shortcut from happening. And you can also, as I mentioned, group DRO is a debiasing method. You can basically use our model with the group DRO. There's nothing against it. You can use both methods together. So the DRO, if you use the debiasing method DRO, this is the performance. If you use the DRO with the baseline counterfactuals, you can see a huge drop in the performance when using the biased methods. But on the other hand, when you use ours, you can see the performance are even better on average in any case, and also on the minority subgroups. So the assumption still holds for the DRO as well. And that's the whole thing. So if you want to recap the conclusion, our framework is an explainable framework to ignore the spurious correlation. And the strength is that unlike the biasing methods, we don't need the subgroup information. So and also on the other hand, we can use any off-the-shelf pre-trained detectors. So let's say that you have a private data set and you don't have the annotations for presence of the artifact, for example, devices. You need some clinician to do annotations for you, and it's going to be time consuming and it's money and everything. So you can use any off-the-shelf pre-trained detector that, for example, is trained by us, and you know that you have those devices in your data, but you don't know who which like subject has the device. So you can use that off-the-shelf detector and just create the counterfactuals, and that's it. Thank you so much, Sarah.